Tubulointerstitial diseases. These diseases primarily affect the renal tubules and interstitial components of the renal parenchyma. They are characterized by tubular dysfunction with electrolyte abnormalities, moderate levels of proteinuria, and varying degrees of renal impairment. Often the urinary output may be relatively preserved for any given GFR, and indeed there may be polyuria and nocturia. Acute interstitial nephritis. Acute interstitial nephritis is an immune-mediated disorder characterized by acute inflammation affecting the tubulointerstitium of the kidney. It is commonly drug-induced, with proton pump inhibitors first becoming the most common cause, but can be caused by other toxins and can complicate a variety of systemic diseases and infections. Clinical features. The clinical presentation is typically with renal impairment, but in some patients with drug-induced AIN, there may be signs of a generalized drug hypersensitivity reaction with fever, rash, and eosinophilia. Proteinuria is generally modest. PCR is less than 100 mg per millimole and tubular in type. The urine may contain white blood cells and white cell crusts but is sterile on culture. Eosinophils are present in up to 70% of patients, but this is a non-specific finding. AIN should always be considered in patients with non-oliguric AKI. There may be a rapid deterioration of renal function in some cases of drug-induced AIN, causing the condition to be mistaken for RPGN. Now, causes of acute interstitial nephritis. There are 4 headlines, among them allergic, immune, infections, and toxic. Among the allergic causes, many drugs, but particularly penicillins, NSAIDs, proton pump inhibitors, mesalazine, delayed. Immune causes includes autoimmune nephritis plus minus uveitis, transplant rejection. Infections causes are acute bacterial pyelonephritis, leptospirosis, tuberculosis, hantavirus. Toxic causes include myeloma light chains, mushrooms. Now, investigations. Renal biopsy is usually required to confirm the diagnosis. This typically shows evidence of intense inflammation with infiltration of the tubules and interstitium by polymorphonuclear leukocytes and lymphocytes. Eosinophils may also be observed, especially in drug-induced AIN. Often granulomas may be evident, especially in drug-induced AIN or sarcoidosis. The degree of chronic inflammation in a biopsy is a useful predictor of long-term renal function. Eosinophilia may be present but is not a good discriminator for AIN. Management. Some patients with drug-induced AIN recover following withdrawal of the drug alone, but high-dose glucocorticoids, prednisolone 1 mg per kg per day, may accelerate recovery and prevent long-term scarring. Other specific causes should be treated if possible. Here the diagram shows tubular histopathology. A normal tubular histology, the tubules are back to back. Brush borders can be seen on the luminal borders of cells in the proximal tubule. In B, acute tubular necrosis, there are scattered breaks in tubular basement membranes, swelling and vacuolation of tubular cells, and in places apoptosis and necrosis of tubular cells with shedding of cells into the lumen. During the regenerative phase, there is increased tubular mitotic activity. The interstitium is edematous and infiltrated by inflammatory cells. The glomeruli are relatively normal, although there may be endothelial cell swelling and fibrin deposition. C. Acute bacterial pyelonephritis, a widespread inflammatory infiltrate that includes many neutrophils, is seen. Granulocyte crusts G are forming within some dilated tubules. Other tubules are scarcely visible because of the extent of the inflammation and damage. D. Acute or allergic interstitial nephritis. In this patient who received a NSAID, an extensive mononuclear cell infiltrate, no neutrophils involving tubules is seen. This inflammation does not involve the glomeruli. Sometimes eosinophils are prominent. Transplant rejection looks similar to this.